Welcome to a brand new edition of Skin Sense, and I'm your host, Jeannine Mazurkiwecz. We're back here with Dr. Steve Schleicher.
Yes.
Getting ready for the colder months, and we have a topic that affects about 2% of the population that we're going to discuss today, and that's obviously
correct.
Millions of people throughout the country.
Yeah, and the condition is called psoriasis. And again, when you talk 2% of the population, you are talking, we have 330 million people. So you're talking many millions of people who have this condition.
Okay.
And the problem with the condition is, number one, it doesn't look good. And number two, it can have some other health consequences to it. And this is kind of new, developments that we'll be talking about.
Later on in the show, again, we're with Dr. Steve Schleicher. We're going to be speaking with two of our guests. We're going to be talking about a study that you might be able to participate in if you do, in fact, have psoriasis. But again, we want them to know that we're located here on Laurel Street in Hazleton, Pennsylvania, and the company now that is running the show here is the Reading Dermatology Association.
That is correct. That is correct. And psoriasis is basically characterized by red rashes, that become scaly. And I'm sure everybody has seen someone with psoriasis because it is so uncommon. And we'll show pictures of the actual condition so you can identify it. Most commonly affects the elbows, the knees, and the scalp. And what you get are these plaques. And these plaques are very red. They're very scaly. On occasion, psoriasis can affect the joints, and it can lead to arthritis, which at times can be very, very severe. Psoriasis can also affect the nails, and we'll talk about that in the next segment with our podiatrist, but it can lead to severe disfigurement of the nails as well. Mm-hmm. So, and the point is, there's hope for people with psoriasis. I mean, it's a very, very frustrating condition because as yet we don't have a cure. All right, and we're getting close though. That's the good thing. I just read today, anybody who has psoriasis, there's a National Psoriasis Foundation. They're wonderful. Do a search for them on the web. Certainly join this organization. It's basically free. And there are now 40 new medications in the pipeline for psoriasis being tested. 40. Which is amazing. So I'm hoping in the near future, we'll be able to actually cure psoriasis. Now we can control it. Mm-hmm. Let's hope we can cure it.
We're going to talk about the treatments in just a bit, but does psoriasis affect a certain age group? Does it affect women more than men? Talk about that.
Yeah, that's a great question. Psoriasis usually starts when people are in their teens, sometimes in their 20s. Sometimes it can start later on in life, and sometimes it can start very early in life. I mean, there are kids, 3, 4 years old who have psoriasis. And one of the things, people should realize is that there is a genetic predisposition to the condition. Mm-hmm. So that if one of your relatives has psoriasis, chances are better for you developing the condition. But not everybody does. I mean, we see many, many family members who don't have it, mm-hmm. and we see other family members who do have it.
You talked about treatments. There are many different treatments. If a family member is on one kind of treatment, will it necessarily mean that you will be on the same treatment, or how does that work?
Well, psoriasis can be very severe or it can be very, very minimal. Mm-hmm. Minimal psoriasis may just, be cleared up by certain creams, by steroid creams, and not require anything else. Psoriasis that is moderate to severe often requires other treatments. I mean, even ultraviolet light, like sunlight, is very helpful for psoriasis. So a lot of our patients get better in the summertime and then they flare up in the wintertime. But there are a certain number of patients who don't respond to topical therapies, and these are the patients who need either oral therapy or injectable therapies.
Now, does psoriasis go hand in hand with other kind of skin rashes or eczema or allergies?
Good question. One thing people should realize, psoriasis is not contagious. Mm-hmm. So, everybody's kind of worried when they see somebody with a skin rash, whether they can catch it. No, you cannot catch psoriasis. And psoriasis, no, it's not related to other skin problems. It can be related to arthritis. But something that we've found out just within the past few years, people with psoriasis have a greater tendency to have high fats, circulating fats in the bloodstream, mm-hmm. higher tendency to develop diabetes, higher tendency to be overweight, and unfortunately they have a higher tendency to develop heart attacks. So just this week, an article was published that showed that if you aggressively treat psoriasis, you may be actually saving that person's life and preventing heart attacks. And there are 3 so-called biologics. These are the injectables that we use to treat psoriasis. They're given either by us in the office or by the patient at home, similar to an insulin needle. And I'll briefly go over the 3. One is called Enbrel. This one is given every week by the patient, okay? The other one is called Humira, and this one is given every 2 weeks by the patient. And there's another one called Stelara. The nice thing about Stelara is it's only given every 3 months, okay? And these are very, very tiny little injections, okay? By tiny, I actually have a demonstration pen here, which is pretty neat, actually. This pen actually talks to you.
Hello. This train pen is designed to help you learn how to self-inject your medicine. It is reusable, has no needle, and contains no medication.
This is an example, okay? And basically, what an individual does, okay, if you have psoriasis and you're on this medication, you are given one of these pens, and it's just a matter of holding it against your body, pushing down, and it automatically injects. Okay, it's simple. It takes whatever, 15 seconds to do the entire injection. And again, what we were talking about before, these medicines are a revolution in psoriasis. Okay, they first came out about 10 years ago. Many more are being developed. But the key thing is they may actually save individuals from problems down the road. Besides, we've seen remarkable clearing with this. We've seen individuals who are covered head to foot, who are virtually 95, 90% clear. And I know there are a lot of people out there who have kind of given up hope with psoriasis. They've had it for a long time. They've probably seen other doctors. They've been treated with creams. I mean, it's really a pain in the neck to put creams all over your body. This is a revolution, okay? So anyone with severe psoriasis, even moderate psoriasis, please contact your dermatologist. Talk about some of these newer therapies.
Now, we talked about skin psoriasis. Now we're going to talk about coming up nails.
Right.
Worrying about psoriasis of the nails, how you can treat it, how it can be detected, because it can be tricky to see. You might think you have just a fungus, and it actually could be psoriasis.
Exactly. It can be very, of course, we all see the nails, and nails can be extremely disfiguring. Believe it or not, these biologics work tremendously for the nails as well.
And then later in the show, we're going to talk about a study that you might be able to partake in and get your treatments free of charge. Stay with us here on Skin Sense. And welcome back to SSP TV. I'm Jeannine Mazurkiwecz, and we're here at the Reading Dermatology Association, and we're with Dr. Schleicher, and we have a guest with us today. We have Rudy Samimi, and she is here to talk about psoriasis, a different topic today that affects 2% of the American population, right?
That is absolutely correct.
And thank you for having us and being on the show here on Skin Sense. We have a lot of fun with it. And tell us about your background. How did you get hooked up here with Dr. Schleicher?
Well, just finishing up my podiatry residency and thought I'd like to go into dermatology a little bit, so I'm doing a one-year fellowship here in Hazleton.
Nice, very nice.
Yeah.
Okay.
People don't realize that there are, a lot of conditions, skin conditions that happen on the lower feet. Okay, so when Rudy graduates, she'll be one of the experts in the country. We have the only training program for podiatrists and dermatologists at the same time.
All right, so again, affecting the nails and psoriasis of the nails. What can you tell us about psoriasis of the nails, and how do you detect it?
So about 5 to 10% of psoriasis patients have nail psoriasis. And what you're going to see, the most common thing with psoriatic nails is this pitting. So basically that's just this little ice pick depression in the nail. And it literally looks like there's little holes in the nail. So, and we have a picture of that for you. And then other things that you might see are oil spots, which is leaking of fluid underneath the nail from the nail bed. And that can be like a yellow to brown spot. And then there's other things that go along with psoriatic nails, but also, overlap with the fungal toenails. But you can have both at the same time. So those things might be called onycholysis. It's when the nail plate, which is what you're looking at, separates from the nail bed, and it usually does that in a regular pattern. And you'll also see some discoloration, like yellowish. You can have white discoloration. You can have linear striation. It's called onychorexia. And and also the ends of the nail plate can attach to the skin underneath. There is a normal attachment, but then it can have an additional abnormal attachment. And like Dr. Schleicher had said before, you're going to have a little bit of deformity, dystrophy to the nail. It's going to look kind of funky. So the way that you are going to differentiate that from fungus is just simply take a biopsy or just take a specimen and grow it in some dermatophyte media. We have some here in the office, and it only takes 3 weeks for fungus to grow in it. Now, you can have both at the same time. And then some more rare things you can have in the nail are splinter hemorrhages, which are just little kind of like blood vessels or just kind of bleeding underneath the nail. You can also get that with endocarditis. So those are some of the main things, you know, the discoloration, the thickening. Now, normal nails thick with aging, and they grow about 1 millimeter per month. So more older patients are going to have thicker nails anyway. And you're predisposed, being diabetic, to have fungus in your toenails, things like that. So,
yeah, I think the main thing is it's disfiguring. And not so much if you have your toenails, but obviously if it spreads to your fingernails or affects your fingernails, everybody sees that every day. And the nails, you know, as was mentioned, you can develop little pits or little holes in the nails. But even more disfiguring, you can develop like distortion of the nails and thickening of the nails. And those are readily obvious to everybody. But it is important to differentiate the two between the fungal infection and psoriasis. We treat them differently. Fungal infections are a lot more common. Everybody's heard of things like athlete's foot, okay? And you know, many of you go to the beach and you see people walking around with either scaling of their feet or toenails that look distorted. Well, the majority of these cases are caused by a fungus. The only bad thing is it's not the easiest thing in the world to treat, even fungus that affects the nails. You have to go on oral medication.
All right, so for psoriasis of the nails, does it work the same way with psoriasis of your skin? It's, you know, it's not contagious. It's
right, correct.
It's not, it could be hereditary.
Correct,
Right.
and also just like psoriasis of the skin, you treat it kind of similarly. Okay, the biologics that we talked about in the first episode work very, very well for the nails, which is good, because before that, the only thing that really worked well for the nails was actual injections of a steroid into the nail base. And you can imagine, it's painful. It has to be repeated, you know, every month or every 2 months. And a lot of people just can't tolerate the pain. So we hardly ever do that anymore. Okay, we have more so-called modern therapies to use that give good control of the nail psoriasis.
Now, could there be problems if you don't treat psoriasis and you don't treat psoriasis of nails? Can you lose your finger?
No.
Okay.
No, it just looks, because the nail becomes more and more distorted. But, you know, one of the things you have to look for too is not only nail distortion, but again, psoriasis can affect the joints, okay, and it can lead to a very severe and crippling arthritis. So many times, certainly if our patients complain of joint pains, we'll get that joint x-rayed, and we'll feel the area, we'll examine the tendons in the area. If they have early psoriatic arthritis, sure, we want to institute treatment, because again, the earlier you start to treat people, the better they're going to feel physically having arthritis. But the hope is that we'll actually prevent some of this joint progression that can actually lead to crippling arthritis.
And finally, is it more common to have psoriasis of your nails in your toes, on your toes, or on your hands?
Another great question. Yeah, it's more common to have it in the toes per se, but if you look closely, you can actually see most people, the most common thing you get with psoriasis are tiny little pits. Most people don't even look that close because they're hard to see. But yeah, if you look closely, many times you'll be able to see them. It's only when they become grossly distorted. Now, fungal infections, sure, that's way, way, way more common in the toenails than the fingernails. Again, very fortunately, because they're visible.
Rudy, thanks for joining us here on the show. Very informative, and I'm sure you're an asset to Dr. Schleicher's team here.
Absolute asset, yes.
When we come back, we're going to be talking about that psoriasis study that you could probably partake in if you do have psoriasis. Again, the treatments would be free to you. We'll have all the information coming up on Skin Sense. And we should mention that Dr. Schleicher just published one of his other books. It's called Skin Disease of the Lower Extremities. And tell us a little bit about this.
Yeah, I actually co-wrote it with a podiatrist, okay? And actually the first podiatrist who did our dermatology fellowship, okay, several years ago. She's now a professor at Temple. And it's a book for mainly the podiatric field, of course for dermatologists too. It's medical, it's got a lot of gross pictures.
I was just going to say, it's lovely pictures in here.
Let me caution, let me caution the audience, it's not X-rated.
No, it's not X-rated. This is his first book that is not X-rated, right?
Jeannine, sorry to disappoint you.
Darn it. Next book. Anyway, we have another guest with us, and Dana Mock is here, right?
That's correct.
And we're talking about this study. We've been promoting it throughout the entire show. And the study is for people who actually have psoriasis.
That's correct. I believe Dr. had touched a little bit earlier on some of the biologics that are currently out and approved by the FDA on the market, Enbrel, Humira, and that. And this is actually a study in order to get a new biologic approved by the FDA out on the market and available for patients. The study itself is actually unique in that there's two phases. The first phase is going to be a 12-week phase where all subjects who do qualify for the study will be given either Enbrel, which is currently on the market, or the new test medication, or what we refer to as a placebo, which I'm sure many of you are familiar with. It's a non-active drug, essentially. I should point out that the drug is given as a subcutaneous injection, and for the first 12 weeks, those injections will take place twice a week. The second phase of the study then is actually a duration up to 5 years, and during this phase of the study, all subjects, regardless what drug they were on in phase 1, whether it be the Enbrel, the placebo, or the study drug medication, will go into phase 2 and be given the study medication. And that's for a period, again, of up to 5 years. And the injections will go from twice a week during the first 12 weeks to once a month during the remaining 5 years. And I'll let Dr. comment if he'd like, but one of the things that we really, obviously getting involved in the clinical research is important for a number of reasons, and testing the medications, but from the patient perspective, it offers, I believe, a great deal of incentive, first and foremost, for those individuals who don't have insurance or their insurance doesn't cover the biologics, which are very expensive, Doctor. They're probably, what, $1,000?
Yeah, and biologics, yes, they can be very, very expensive, okay? We're talking about $2,000 per month for some of these products. Fortunately, many insurance companies do pick up most of the expense, and there are foundations who may pick up the remainder of the expense, but there are a good number of patients who cannot afford to go on these medications. By doing a study such as this, yes, we'll be able to get individuals with psoriasis the medication, which could be a godsend.
And again, that is up to a duration of 5 years.
Right.
In addition to the medication being provided at no charge, obviously all the medical exams, which would be conducted obviously by Dr. Schleicher himself, would be no charge, any type of laboratories in that. And as a last incentive, the company also offers a reimbursement, if you will, to allow the patient to recover some of the costs for the extra visits and so forth. So by the end of 5 years, you know, hopefully the patient has done well on the drug and has been able to, you know, get a little bit of compensation for their time and travel.
Well, some of my questions that I would have, and some people who might have psoriasis would have, what is their commitment to the study? what exactly are you looking for on their end? And
Well,
then how do they contact you and get involved?
Sure. Right now, we just received approval for the study, and so we are currently actively enrolling. We're going to be obviously promoting it on your show, as well as running some local advertisements in the paper. But we're looking for individuals who are 18 years and older who do have a diagnosis of plaque psoriasis, or if they believe they may have it and perhaps have not been diagnosed by a dermatologist, we could certainly bring them in for a screening visit, have Dr. Schleicher examine them and move forward accordingly. There's some criteria, obviously, some inclusion-exclusion criteria for anyone who does have psoriasis and is currently using a biologic. The biggest criteria is that any individuals who have already been on Enbrel would not be eligible for the study. But aside from that, pretty standard.
Yeah, it's really, again, it's for people who have moderate to severe psoriasis, okay? So by moderate, we mean approximately 10% or more of your body's surface covered with psoriasis, which is not that uncommon, okay? And psoriasis, as we talked about, can be a very, very devastating condition. And also what we talked about is the fact that, you know, if you treat psoriasis with certain medications, you may be able to help prevent, you know, things like heart attack later on in someone's life. So that's something we very, very, very strongly advocate at this stage, because the studies are looking good that medicines such as the biologics, you know, may actually save lives and prolong lives in people with psoriasis.
How much time are we talking on the patient throughout these years? Is it once a week? Is it once a
Well,
month?
during the first 12 weeks, we would see you on a weekly basis for the first month, and then we go to every other week for the remaining 2 months. After that, actually, for phase 2, where the patients are going to be getting the injections, and we're actually going to be training the patients that they can give these injections to themselves in the convenience of their own home. And it's a very, very easy self-injecting needle pen, if you will.
Which we've talked about.
And so at that point, once they get into phase 2, patients are only required to come into the clinic here, the office, I should say, every 3 months. And there are some little incentives. 5 years is obviously a long time to participate.
Right.
Again, by getting the examinations at no cost, the medication at no cost. The company is also offering little incentives here and there, milestones, if you will, along with reimbursement for their time and travel, you know, in the form of, you know, whether it be cooler packs or, you know, T-shirts or hats, things like that.
So if they want any more information on this, they can call directly here?
They could actually, the best number to call would be our study nurse, Marianne Guza, and her direct line is area code 570-582-7180.
All right, and give her a call. Psoriasis, like we said, 2% of the American population, which is a lot, and in this area, I'm sure we can get enough people for the study.
Yeah, and again, I'm hoping for a cure, but until we have a cure, it looks like the biologics are the best thing. And let me just add that one of the biologics, Enbrel, has been out now for well over a decade. Okay, so in the safety issues, it seems to be a tremendous drug. It seems to be safer than some of the therapies that we used before for psoriasis, some of the oral medicines, which are actually anti-cancer drugs that we use for psoriasis. So the biologics, yes, they do appear to be very, very safe.
And Phil Mickelson, the golfer.
Yeah,
uses
well,
Enbrel,
that's
so-
right. And you know, everybody has heard of the biologics because the 3 that I talked about before, TV ads, they have celebrities, they have, you know, models, actresses, golfers, whatever, who are advocates because they're doing so well on these medications.
Very good. Thank you for joining us, and for both of our guests that were on today. Again, thank you for all of your comments and feedback on the show and the procedures that we do here with Dr. Schleicher. If you need any information, you can call the number direct on your screen or just stop by. Thanks for joining us here on Skin Sense.